Tale of Two Hygienists presents this week's TIPisode. Quick and easy tips to keep you up to date and presented by the experts in the profession. Now, get ready for your unofficial TIPisode. This week brought to you by GC America.
Happy day, everyone. My name is Andrew Johnston, and for those of you that listen to our main show each week, A Tale of Two Hygienists, you might recognize my voice. I am here speaking to you today to answer a very simple question. Are restorative hygienists real? And the follow-up, of course, to that question is, what qualifications do they have, and what role would they play in the dental practice? And I know some of you hygienists are like, whoa, hard pass. I have zero interest in this topic. Don't make me do fillings also. And I say to you, just give this a listen anyway. You might learn what other people in your profession are doing, and when you learn that, you'll be able to better support them if you understand a little bit. For the doctors that are listening in, also the office managers, there is a business advantage to having a restorative hygienist, and I'll explain that at the end of this. So please stick around and listen for that. So the simple answer to the question is yes, which I kind of already answered that. Restorative hygienists are real. They are a thing. Although many of them are simply hygienists with the ability to place restorations as part of their scope of practice, the term restorative hygienist has usually, at least in my state, been used when the sole responsibility of that hygienist each day or that day was to do restorative. Those that go between traditional and restorative procedures are usually termed hygienist. A restorative hygienist is not an EFTA, which stands for Expanded Function Dental Auxiliary in most states, or Expanded Functions Dental Assistant in other states, nor are restorative hygienists that elusive mid-level provider. A true restorative hygienist is one that has had as part of their curriculum education on restorative materials and the placement, adjustment, and finish thereof. They have also taken a third-party board exam to prove competency. A restorative hygienist can place any type of material for which a class of prep is indicated. They have the education and training to collaborate with the dentist in selecting the appropriate materials. Although, to be very clear, they always take the instruction of a dentist on selecting that material. To be very, very, very clear. But there's a nice collaboration going. And since this TIPisode is sponsored by GC America, I wanted to share a little bit of what I've learned in regards to making that case selection of what material you're going to use. So here's a little bit of education in this here TIPisode. So buckle up. Hopefully we all remember good old GV Black's caries classification system, because this is one of the primary indicators of which type of restorative material to use. It's all about location, 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 right? The location of the restoration tells us what types of environment the filling will endure and whether it needs to be able to withstand occlusal forces or have some flex to it, be aesthetically pleasing or resist acids or what have you. It also helps us predict how successful the placement of that filling will be due to factors like saliva, moisture control, strong tongue, the ability of someone to open wide, etc. So here's my general decision tree when suggesting a restorative material to my docs. I feel like at this point in our lives, amalgam fillings are kind of becoming a thing of the past, which is a little bit sad for me because they are by far my favorite one to place. There's just something about condensing and carving that is really satisfying. For the sake of this discussion though, let's say that this is still a part of our armamentarium. I would use alloy exclusively in the posterior with some consideration to even making them exclusively in the molars. But this is a purely aesthetic choice to relegate them back to the molars. I have no issue with their functionality in the premolars. Outside of aesthetics, I would say that alloy is great when moisture contamination is an issue, TMJ issues are present and the patient needs a quicker filling placed, or the patient is high caries risk and I'm concerned about the integrity of the margins over time. For composite, look, I just don't love them as they're very technique sensitive and the time that it takes to place a good one can be extensive. Composites should truly only be placed with a rubber dam on a patient, which they don't love. There are good evacuation systems as the next best option to a rubber dam, but really the rubber dam is the gold standard still. I would mainly suggest a composite in an aesthetic situation. Aesthetics could be anterior, posterior, doesn't matter. There are some really amazing composite materials out there that mimic the appearance of enamel extremely well. One key indicator of using a composite in the posterior outside of aesthetic concerns is if the doctor that I'm working with is a slot prep doc, meaning that that prep is very narrow in nature and they're trying to be as conservative as possible. Then composite is the better choice than alloy due to the chemical retention factor. Alloy just wouldn't lock in. So traditionally, those are the choices. Obviously, I don't love the drawbacks of composite, but it is way better aesthetically than alloy. Also, the patients want composite, and that's huge in a practice. In the interest of keeping this TIPisode a little bit shorter, I'm not even going to begin to talk about the failure rates or replacement rates for each of the types of the material, but a quick search on how long composites last versus alloy is certainly telling. So in making my decisions, glass ionomer is always on my mind. It takes the best properties of both alloy and composite and puts them together. I can put some Fuji Equia Forte in just about any area I would put an amalgam, whether it's class 1, class 2, class 5, which are the most ideal. I know that it will stand up to the occlusal forces, it'll stand up against the acid attacks, it releases fluoride back into the area, and that prep can be bulk filled just like alloy is. You won't get that shrinkage stress. There are 8 shades, so I can easily find close matches to the surrounding 2 structure, but you may have noticed that I didn't include class 3 or class 4 in my recommendations, and you might be thinking, Andrew, what about the anterior? So with Equia Forte, there is a little bit of an opacity issue. But with the next generation of Equia Forte, which is Fuji Equia Forte HT, fixes that problem. HT standing for high translucency, and that is what you would put in the anteriors. So as promised earlier in this, I want to take a few minutes to talk to the doctors and office management out there. I know that many hygienists got into this profession to help people get healthier, and I think that that's admirable. There's also a large contingent of hygienists who love the aspect of working with their hands and who are naturally artistic. For these types, restorative hygiene fills a void that SRP simply cannot. So doctors, I want to introduce you to the hybrid model, where the hygienist in your office gets what they need for job satisfaction and you get what you need with retention of your staff and an increase in production. Let's assume for a minute that a dental office has 1 doctor and 2 hygienists. One of those hygienists is a restorative hygienist. What are your expectations for average production per hour from a traditional hygiene chair? $120 an hour, $150, $200. I would say for the sake of math though, let's agree that $150 of production per hour per hygiene chair is reasonable. Now let's take that restorative hygienist, and instead of having them see your traditional hygiene patients, we schedule a day in which all they do is place fillings. They could average 2 fillings per hour with an average filling cost of, we'll say, again, $150 just for the sake of math. Now they're making, if they're doing 2 of those an hour, $300 an hour in that chair. And you're thinking, yes, that is twice as profitable as our traditional hygiene. But I want to take it a step further because it doesn't stop there. If your restorative hygienist is doing all of your simple restorative work, that would free you up, the doctor, to do major restorative. In that same 2-hour block that they have done $600 worth of fillings, you could have done another $1,000 or more in endo or crown and bridge or what have you. And to tie it all together, the only way that this system works is with an educated restorative team, case selection, and properly treatment planned appointments with the appropriate restorative material. So hopefully that answers the question of, are restorative hygienists real? What are the qualifications? And what role could they play in the dental practice? Thank you for listening to another one of my TIPisodes. If you have any questions or suggestions, please email me at andrew@ataleoftwohygienists.com. And please check out the show notes for links to the products that I mentioned. I cannot say enough good things about the lunch and learns that my dental teams are experiencing right now with the GC America reps. I highly recommend you reach out and get one scheduled. If you're a hygienist or another team member, get one scheduled for your docs and show them how committed you are to the success of the practice. Thank you again and have a great week, everyone.
Thanks for listening to another TIPisode, and thank you to GC America for sponsoring this week's episode. You can find out more about their great products at gcamerica.com. And don't forget to hit the subscribe button in your podcast app. Follow us on Facebook or Instagram, and head over to our website, ataleoftwohygienist.com, to sign up for our newsletter. And we always appreciate ratings and reviews. Thanks again for listening to your unofficial dental hygiene podcast.